Okay. I appreciate the opportunity to give an update on COVID-19 particularly as it regards patients with MS. This is a huge topic that I probably have at least 20 to 30 emails every day regarding some aspect of MS and COVID in different studies. I'm going to summarize something first, and then after that I'll give some information about some of the resources and some of the ideas that are coming out of that. So the big question that people have is, will MS or will the disease-modifying drugs increase someone's risk of getting infected? And the answer to that is no. There is absolutely no reason so far to believe that MS itself or that MS itself will increase the risk of someone having COVID virus infection, or that having MS will increase the consequences of the illness. In other words, if someone has MS, we do not anticipate that they'll have a worse outcome if they did get the virus. So that question is being answered in the several registries that are underway that I'll mention about at the end of this. But a more complicated question is the effect of the disease-modifying therapy. It's a much more complicated question. We have multiple therapies with different actions and different side effects. So this is early days, so our data is not firm. As the registries expand in extent and conclusions are drawn, we might have more information, but currently we don't do that. So recommendations like we recommend for MS, there are different drugs for different people. There are going to be different recommendations depending on which particular disease-modifying therapy that someone is taking. So it's going to be a very individualized thing. What we do state is that the older injectable drugs, such as the interferons, all of the interferons, and glatiramer, we feel are extremely safe. Also, Tysabri, natalizumab is also generally felt to convey a little additional risk. There is a slight risk for this virus to actually affect the nervous system, but overall, though, still we do not feel that. We feel that Tysabri in this era is a safe drug. Considering the oral agents, teriflunomide, Elbagio, and dimethyl fumarate Tecfidera, or the newer version of Tecfidera, the similar drug, Vumerity, we feel have very low risk in general as well. With the exception that if a drug like Tecfidera or Vumerity lowered the lymphocyte count, and we know that some patients on those drugs have a lowering of their lymphocyte count, then they might be at increased risk for developing a complication of the COVID virus. So in patients on those drugs, Tecfidera or Vumerity, I am recommending we monitor their lymphocytes more carefully, especially early on, because people that have low lymphocyte counts tend to develop those early on. So if patients are on those drugs and their lymphocyte count is low, then they could be in a higher risk group, so important to monitor the lymphocytes. Then there's a group of drugs that are similar, which is firstly the oldest one being fingolimod, which is 10 years old now, Gilenya. A newer drug in that group called siponimod, Mayzent, and even a newer drug in that group, ozanimod, which is released by the FDA, but has not even been marketed yet because it arrived on Earth at a bad time. These drugs all work on the sphingosine-1 receptor, and these drugs basically restrict the lymphocytes to the lymph nodes. So they do not wipe out or deplete the lymphocytes. They just deplete them. They just deplete them in the circulation by restricting them to the lymph nodes. And therefore, we feel that they have a slightly higher risk of infection. But the final group of drugs is the drugs that are what we call cell-depleting drugs, which are drugs that actually work by destroying certain types of white blood cells. So certain of these drugs are B-cell deleters. They destroy certain types of B cells, and the most commonly used drug of this type for MS is Ocrevus, ozanimod, and rituximab has also been used for this off-label. And then we have other drugs that also deplete cells, immune cells, which are Lemtrada, which depletes both T and B cells, and Mavenclad, which can also reduce these cells, although not to the same extent. So any of these cell-depleting drugs would mean that someone would have less ammunition to fight COVID infections and should be considered very carefully. Let me add that there's no consensus with these drugs. I've listened to multiple webinars where, for example, let's take Ocrevus. Some people would say Ocrevus should not be given at all during the era of the COVID virus. Other people are saying, well, there's no problem. It's most important to treat the disease as long as someone then, practices safety guidelines. treat the disease so there's no recurrence of or activity of the MS. And then there are people who say with Ocrevus, monitor the B cells, and when they start to recover, that might be the time to do the infusion. So in some patients on Ocrevus, we're monitoring the B cells. When they start to return, that could be the time for the infusion to be given. So some of the resources where we're going to get information in the future are the registries. The registry in the US is COVIMS or COVIMS, C-O-V-I-M-S, sponsored by the National MS Society and the Consortium of MS Centers. And COVIMS, as of last Friday, had about 130 patients, mostly MS patients, a few NMO or MOG patients. But the majority of these patients are MS patients. And the distribution of these is very similar to the way drugs are currently being prescribed for MS. In this registry, we have not seen anything different from the general population of people. And it's too early to conclude what specific results are on specific drugs. What does a particular drug do? We don't know yet. I can mention to you that the European study is much larger, several hundred patients, so we should get some information from that soon about what are the different outcomes maybe with different drugs. I can further say to you that some of the people that have succumbed or had bad outcomes with COVID virus is because there is the immune system overreacting, causing severe inflammation. For example, in the adult respiratory distress syndrome, the immune system overacts and causes massive inflammation in the lungs. And therefore, if a drug actually suppresses the immune system, they might do better. And there, in fact, are some studies going on in Europe where actually interferons and fingolimod are being given to patients to see if it can mitigate their response to the drug and maybe improve their outcomes. So these are all very interesting things that we're about to learn. The sites that I use for referral in the US, I always look to the National MS Society information. I look to the Multiple Sclerosis International Federation, and there's also a nice summary from the Association of British Neurologists, ABN. All of these look at the different drugs and make comments about the different drugs and give some ideas about what drug to use and when to use it and those comfort levels. So at the end of the day, I would say that our choices and our decisions are going to be based on a number of things. They're going to be based on the individual, on their medications, on their underlying immune system. For example, if someone has other risk factors, we know that people with comorbidities, diabetes, obesity, hypertension, heart disease, COPD, chronic asthma, those are referred to as comorbidities. Those conditions increase the risk of an adverse reaction to COVID significantly. So if somebody had those, it might change the kind of drug we're going to give them because we may not want to tamper further with the immune system. So individuals are very important, and similarly the community. If it's a community with a very high risk of COVID-19, I might have, for example, a different approach to somebody in a very quiet rural community that's seen half a dozen COVID-19 patients to New York City, where there have been, unfortunately, thousands of them. So those are some main concerns that I have in terms of the drugs themselves and the therapy. I would add three final thoughts. We're talking very frequently about the physical health of people. Let us never forget also that there is also the emotional health, and we certainly will see a lot of that. Depression is common in MS to begin with, and now that people are down and lonely, and I find this on my teleconferences, telemedicine discussions, a lot of people feeling quite isolated. So mental health issues we should not neglect, and finally also the economic health. So mental, physical, and economic health are all also big items going forward, apart from our big decisions about what drugs, how to monitor them, who to use them, how to use them. And so with that, I bid you all good night. If there's any questions, I told Stuart he might text me. I'm in another program currently, and then I could try and answer the questions or maybe come on at the end of this, depending how our times meet. So good night and good luck to everyone. Thank you.